We will explore the etiology of post-treatment disease in endodontics, focusing on understanding persistent endodontic disease and how we can better manage it. In the past, undesirable outcomes of endodontic therapy were often termed failures. Clinicians frequently quoted failure rates based on success-failure studies. This terminology reflects an outdated thinking process where successes were celebrated and failures were blamed on the clinicians. This mindset can be potentially destructive. There are many instances where treatments performed with high clinical competence result in undesirable outcomes, and conversely, some procedures performed below acceptable standards still provide long-term success. It's crucial to separate science from emotion and ego. Friedman suggested a shift in terminology, advocating for the term post-treatment disease instead of treatment failure. This new nomenclature helps patients and clinicians focus on the concept of disease, treatment, and healing, rather than the negative connotations associated with failure. Endodontic therapy is generally reliable, with nearly 16 million root canal procedures performed in 1999 alone, and success rates ranging from 86% to 98%. Despite these high success rates, the incidence of post-treatment disease, although small, translates into a significant number of cases requiring further treatment. When faced with post-treatment disease, it's essential for the clinician to determine the etiology of the persistent pathosis. Understanding the root cause of the disease is crucial in devising a rationale and strategy for effective treatment. There are several causes of post-treatment disease. These include iatrogenic procedural errors, such as poor access cavity design and perforations, untreated major and accessory canals, poorly cleaned and obturated canals, and complications arising from instrumentation. Additional causes include overextensions of root-filling materials, coronal leakage, persistent intracanal and extracanal infections, and the presence of radicular cysts. These etiologies may be apparent at the time of diagnosing the diseased tooth or may remain uncertain until successful therapy is completed. Identifying the cause of post-treatment disease can sometimes be immediate, or it may take years to become discernible. In some cases, the cause may never be known. However, the most important factors for clinicians are those related to treatment planning and determining the prognosis to ensure the best outcomes for our patients. To treatment plan effectively, the clinician may place the etiologic factors into 4 groups. Persistent or reintroduced intraradicular microorganisms, extraradicular infection, foreign body reaction, true cysts. When the root canal space and dentinal tubules are contaminated with microorganisms or their byproducts, and these pathogens contact the periradicular tissues, apical periodontitis ensues. Inadequate cleaning, shaping, obturation, and final restoration of an endodontically diseased tooth can lead to post-treatment disease. Persistent or reintroduced microorganisms are considered the major cause of post-treatment disease. Many iatrogenic treatment complications, such as creating a ledge or separating an instrument, result in the persistence of bacteria in the canal system. It is not the complication itself, but the inability to remove or entune these microorganisms that leads to disease. For successful endodontic therapy, the canal space must be free of bacteria, the obturation should adequately entomb any remaining bacteria, and new microorganisms should not be allowed to re-enter the cleaned and sealed canal space. Failure in any of these areas can lead to post-treatment disease. Infected root canals of untreated teeth generally contain a polymicrobial, predominantly anaerobic flora. However, cultures of infected, previously treated root-filled teeth often produce very few or even a single species, predominantly gram-positive. A commonly isolated species in these cases is Enterococcus faecalis, which is resistant to canal disinfection regimens. If previous root canal treatment was performed poorly, such that the canal space contains no obturating material in the apical half, its flora is more typical of the untreated necrotic infected pulp than that of classic failed root canal therapy. While bacteria are primarily blamed for post-treatment disease, certain fungi, notably Candida albicans, are frequently found in persistent endodontic infections and may be responsible for the recalcitrant lesions. We will discuss extraradicular infections in endodontics, focusing on understanding periradicular infections and their implications for root canal therapy. Extraradicular infections can occur when bacterial cells invade the periradicular tissues. This can happen through direct spread of infection from the root canal space, via contaminated periodontal pockets that communicate with the apical area, by extrusion of infected dentin chips, or by contamination with overextended, infected endodontic instruments. Usually, the host immune response will destroy these invading organisms. However, some microorganisms are able to resist the immune defenses and persist in the periradicular tissues, leading to ongoing infection. Microorganisms can persist in periradicular tissues by producing an extracellular matrix or forming a protective plaque. These mechanisms allow them to evade the host's immune defenses and maintain their presence in the tissues. Two key species of microorganisms that can exist in the periapical tissues and may prevent healing after root canal therapy are Actinomyces israelii and Propionibacterium propionicum. Their presence in the tissues can complicate the healing process and require additional treatment measures. We will discuss foreign body reactions in endodontics, focusing on non-microbial causes of persistent endodontic disease and their implications for treatment. Occasionally, persistent endodontic disease occurs even in the absence of discernible microorganisms. This phenomenon is often attributed to the presence of foreign materials in the periradicular area, which can provoke an inflammatory response. Several materials have been associated with inflammatory responses, including lentil beans and cellulose fibers from paper points. These foreign materials can inadvertently find their way into the periradicular area and cause persistent inflammation. In the ongoing debate about which endodontic obturation technique is superior, much discussion has centered around the impact of overextended root canal filling materials on apical healing. Generally, studies show that filling material extrusion, either flush to the radiographic apex or grossly overextended, leads to a lower incidence of healing. Many of these cases involve not only overextension but also inadequate canal preparation and compaction of the root filling, whereby persistent bacteria remaining in the canal space could leak out. Many cases of overextended fillings also involve inadequate canal preparation and poor compaction of the root filling. This allows persistent bacteria to remain in the canal space and potentially leak out. While gutta-percha and sealers are usually well tolerated by apical tissues, improper technique can introduce bacteria and hinder healing. Despite the potential issues, healing can still occur in the presence of overextended filling materials if the tissues have not been inoculated with microorganisms through vigorous overinstrumentation. Proper technique and avoiding contamination are crucial for successful healing in these cases. True cyst is one of the etiologic factors of post-treatment disease. Periapical cysts form in the periradicular tissues when nests of epithelial cells, retained from tooth development, begin to proliferate due to the chronic presence of inflammatory mediators. These epithelial cell rests of Malassez are the source of the epithelium that lines cystic walls. Cyst formation may help separate the inflammatory stimulus from the surrounding bone. The incidence of periapical cysts has been reported to be between 15% and 42% of all periapical lesions. However, determining whether a periapical radiolucency is a cyst or a more common periapical granuloma cannot be done with available radiographic methods. Clinical assessment plays a crucial role in identification. The incidence of periapical cysts has been reported to be between 15% and 42% of all periapical lesions. However, determining whether a periapical radiolucency is a cyst or a more common periapical granuloma cannot be done with available radiographic methods. Clinical assessment plays a crucial role in identification. There are two types of periapical cysts, the periapical true cyst and the periapical pocket cyst. True cysts have a contained cavity or lumen within a continuous epithelial lining, isolating them from the tooth. Pocket cysts, however, have a lumen that is open to the root canal of the affected tooth. True cysts, due to their self-sustaining nature, likely do not heal following non-surgical endodontic therapy and usually require surgical enucleation. When a patient presents with post-treatment disease, clinical decision-making involves determining the cause of the persistent disease and making an assessment of the best treatment approach. Accurate diagnosis and understanding of the pathologic condition are essential for achieving a successful outcome.